So are you all ready for the next section, which is on monitoring on ART and switching to second-line regimens? So routine monitoring hasn't changed since the old guidelines because dolutegravir, tenofovir, and intracitibine has the same monitoring as TEE, only really being creatinine, which we're doing exactly as we did before. CD4 count is before, and then if clinically indicated, 12 monthly, viral load, month 6 a year and annually. Then the only thing that has changed is our cholesterol and triglycerides monitoring. So that has decreased now. We don't do a baseline anymore, and we only test at month 3. If the cholesterol or triglycerides is high at month 3, we'll repeat a fasting cholesterol and triglycerides. If it is still abnormal, then you consult an expert. If it is fine, we don't continue monitoring. And then remember to always check hemoglobin and Hep B surface antigen when changing to second line, because we want to check if the Hep B surface antigen is positive. We know we want to keep the tenofovir on board to control the hepatitis B, and if the HB is low, then we aren't going to want to use AZT. Viral load monitoring. Now I'm going to go through this quite slowly through the diagram so that you all have a very clear picture of it, because you are going to be training from next week. So our virological suppression definition from now on is a viral load under 50. Okay. Any viral load over 50, we are calling a medical emergency and we require action. Gone are the days where we look at a high viral load and we just leave them. Okay? Viral load above 50 means action. A viral load more than 50 means that viral replication is taking place. And if there are drugs on board, that means the patient can develop resistance. So we need to do a thorough assessment and manage them appropriately. So let's just understand a little bit about HIV resistance. So HIV, its sole purpose in life is to replicate. It enters your body, enters the CD4 cell, and replicates. Releases a whole bunch of new little baby HIV viruses. They infect more CD4 cells. They go inside, they replicate, release more HIV viruses. This happens every second. HIV multiplies so quickly. In one day, it can replicate and make 10 billion new HIV viruses. That's how quickly HIV replicates. But when it does this, it makes mistakes. It's not a very soundproof replicator. It makes lots of mistakes, and we call those mutations. So each new little HIV virus that comes out, if it has a mistake, it is a mutant virus. Now, some of those mutant viruses might be resistant to the ARVs. So if we allow HIV to keep replicating and making lots of mutant viruses, that's when you can develop resistance. So the genetic barrier to resistance, I mentioned this earlier and said I'd elaborate on it. What that means is that some drugs, like efavirenz, nevirapine, 3-TC, emtricitabine, they only need one mutation to become resistant to that drug. So we call that a low genetic barrier to resistance. So the HIV multiplies, it makes one mutation, and now it's resistant to those drugs. So it can happen very quickly and very easily. That's why our old first line, which had efavirenz and 3-TC in it, had a very low genetic barrier to resistance. And we saw people become resistant very regularly. And that's why so many of them had to go onto PIs, onto the lopinavir-ritonavir regimen. Lopinavir-ritonavir, on the other hand, has a much higher genetic barrier. So it needs 5, 6, 7, 8 mutations to develop before the virus is resistant to lopinavir-ritonavir. So that's why our lopinavir-ritonavir regimens work for longer and resistance does not occur as quickly. Then dolutegravir has an even higher genetic barrier to resistance. And we hope that we won't develop resistance to it unless we have patients who aren't taking, the correct dose with TB treatment, etc., if it's not being taken correctly. But that's where the difference comes in between this low genetic barrier and high genetic barrier. Is that clear? Okay, great. So the assessment that we do, as soon as we see a high viral load over 50, we say it's a medical emergency. And what do we do in other medical emergencies? We do our ABCD. Remember ATLS and ACLS when you last did your compressions. So that's exactly what we're going to do for a high viral load as well. A stands for adherence. We're going to assess adherence. What factors might be influencing their adherence? Medication side effects, mental health status, depression, alcohol, substance abuse, poor social support, non-disclosure, living with a partner who they haven't told they have HIV, all of those factors. B is for bugs, other infections. Are there any other infections going on? Check the patient out clinically and for symptoms and signs of infection. C stands for correct dose. Were they given the correct dose? Because if we underdose a patient, they can develop resistance. The level of ARV in their blood will be too low, and HIV can start replicating, making those mutations, and that's how we get resistance. So what can cause people to be on the incorrect dose? Children, when they gain weight, and we just copy the script from the previous script, and we don't check their weight, we don't increase their dose appropriately for their weight. Other dosing issues can be drug-to-drug interactions. You're on rifampicin, we need to increase your dose. Or things like renal failure, etc. Then drug interactions. D has an entire block for itself. D stands for drug interactions. Remember to look for all of those, particularly TB. And then E, this one was a little bit of a push. It stands for resistance. So this is the last cause of why this person's viral load might be high. They might have developed resistance. And that's obviously why we want to then address all of these other things that we can, anything that was wrong, and ask them to take their treatment now for 3 months, and that's when we repeat the viral load, and then if it's still high, we know that it was resistance. But if it's come down, it's suppressed, then it was one of these other things that we've now addressed. So to look at the viral load monitoring algorithm. So our routine viral load monitoring will still be at 6 months on ART, then 12 months, and then 12 monthly after that. If it is less than 50, we will continue routine viral load monitoring, as according to that. If it is between 50 and 999, or if it's over 1,000, we're going to do this ABCDE assessment. So it's anything over 50, and we do ABCDE. Then, what are we going to do once we've assessed all these things? We're going to implement something to sort them out. Whatever we found that is the problem, we now have to address it and make a plan to change that. And then we give them 3 months to repeat the viral load. And in case you guys haven't seen our national adherence guidelines, they're actually really good. Go home, take a look at it, bring that into your training. So then we repeat the viral load after 3 months. Now, that repeat viral load, if it is less than 50, we'll continue routine viral load monitoring. If it is between 50 and 999, we will continue enhanced adherence support and repeat the viral load in 6 months. Okay, this is where that was coming in. And then again, if that repeat is less than 50, we go there. If it's over 1,000, we go there. And if it's again 50 to 999, we go back here and we'll do enhanced adherence again. Okay, this area is a bit of a gray zone. You know, when you get one viral load that's up and then it suppresses again, we can say, okay, that was a viral blip. But if it stays up, then we say there's what do we call it? Persistent low-grade viremia. And that can be an indication of resistance coming. You know, 1 mutation, 2 mutations, and it can develop. So that's why we want to monitor these people quite well. We don't want to just leave them. So there is a little box down here saying clients who have persistent low-grade viremia of between 50 to 999 copies per mil should be discussed with one of our helplines listed below on a case-by-case basis. Okay? But the patients who have repeatedly viral loads between 50 and 999 are going to be a very small proportion. Okay, so that's why we say those ones can be discussed with an expert case by case. If the viral load is over 1,000, now this is where we're going to have 2 different ways of managing depending on what drugs they are on. If they are on an efavirenz-based regimen or nevirapine, so our old NNRTI-based regimen, our same definition remains from previously, that if they have 2 high viral loads over 1,000 on 2 consecutive occasions and adherence issues have been addressed, we will consider switching to second line. Okay, simple. Now, for our new patients who are on either dolutegravir or on a PI-based regimen, because remember, these both have high genetic barriers to resistance. They don't get resistance in 1 month or 2 months. They need a long time to develop resistance. There's a big clause there, as long as they have been given their treatment correctly and they weren't on, say, rifampicin without having the double dosing. Okay, those patients can get resistance quickly. But if they were on their treatment correctly, no drug interactions, these patients should take a long time to develop resistance. So that's why our definition for treatment failure in these patients is only if they've had a viral load over 1,000 on at least 3 occasions over a course of 2 years. Okay, so it's not just 2 high viral loads and it's treatment failure and we switch. Now it's 3 high viral loads over 2 years. Clear? Okay. So our switching now for virological failure now depends on their current regimen and their duration of ART. Okay. Then this is just a reminder to everyone, and we want you to include this in your training that you do in your provinces, just to remind everyone about the fantastic high viral load results for action reports that our NHLS makes for us. I hope everyone here knows about them. Get your facilities to sign up for these reports. You can get them daily, weekly, with all the patients in your facility who have a high viral load and need to be managed. It's a wonderful tool that we have. I think our country was very advanced when they made this, so please encourage people to do it, and this is how to register if you haven't registered. This is what the report looks like. If you haven't seen it, it basically gives the district, the facility, the folder number, patient name, details, and then it'll say, these are the patients with high viral loads. And then we know, okay, pull those files, manage these patients. Because remember, it's an emergency. Okay. Then our second line regimens for adults and adolescents, the progression will be an NNRTI-based regimen. That's because we have the patients who are on that already now. If they fail, they'll go on to a dolutegravir-based regimen. If they want to conceive and don't want to take contraception, don't want to risk dolutegravir, then they'll take a PI. And then if they fail this again, they can then go onto a PI-based regimen. And this is actually quite a cleverly made algorithm because you'll see now when I tell you the big difference between dolutegravir-based regimens and lopinavir-ritonavir or PI-based regimens. One of the big differences is that on lopinavir-ritonavir, on a PI, we don't always need to have 2 active NRTIs with that PI in order for the patient to suppress their viral load. And we should all know this already because it has been the basis of our ART program already. We all know that you don't qualify for third line unless you have PI resistance. So it doesn't matter if your PI is working, if all your NRTIs aren't working, we'll say it's fine. You still give that PI with 2 non-working NRTIs, and the patient will generally suppress their viral load. So only when they have PI resistance do they qualify for third line, and that's when we give them third line ARVs. So in keeping with that, it's nice to have the PI-based regimen at the end, so it doesn't matter if you've gone through your NRTIs already and they aren't working by the time you get there. Whereas dolutegravir, it's very important to know, we do not have the same data for dolutegravir. So at the moment, dolutegravir has to be given with at least one other active NRTI. We will see what the evidence comes out to show, if we can or can't in the future, but for now, we do not want to risk it. We don't want to risk getting dolutegravir resistance, so please never give dolutegravir with 2 failing NRTIs. We want at least one active NRTI with dolutegravir. So that's the basis now of our regimens and how we switch from first line to second line. So you'll see, in adults with virological failure, if they are on an NNRTI-based regimen, which would usually be our TEE, we do not do a resistance test, as per our old guidelines. If they are hepatitis B negative, they change to AZT, 3TC, dolutegravir. Okay. So remember, that's giving nice 2-drug switch. And tenofovir and AZT are great drugs to switch if there's failure, because AZT actually makes tenofovir work better and tenofovir makes AZT work better. So those 2 are good ones to switch. So if they were on tenofovir, now they'll get AZT. If dolutegravir is not suitable for contraceptive reasons or others, then we'll give them AZT, 3TC, lopinavir, ritonavir, as we used to. If they are hepatitis B surface antigen positive, then we are going to give them tenofovir as well as AZT and 3TC and dolutegravir, because we still want these 2 new active drugs, the AZT and the dolutegravir, but we also want to keep them on tenofovir just for their hepatitis B, so that tenofovir becomes just an extra purely for their hepatitis B. Okay, then you'll see the difference is when they were on an INSTI-based regimen, if they failed TDF, 3TC, DTG, then we're generally not doing resistance testing, but it may be required under expert consultation. Okay, so only experts will be able to do it. And the reason for this is that it's just too expensive for us to do resistance testing on everyone who has a high viral load on dolutegravir, because 99% of those patients with a high viral load on dolutegravir is because they're not adherent. There'll be very, very few of them who actually have developed resistance to dolutegravir. That's why just if you have a very concerning patient that you really are worried about resistance in, that's when you could, through a consultant, discuss a resistance test. Otherwise, if they fall under that criteria of 3 high viral loads over 2 years, then you will just change them directly according to this algorithm, where if they're hepatitis B negative, they'll get AZT, 3TC, lopinavir, ritonavir, which is a nice 2-drug switch. If they're hepatitis B positive, we would have to give them, like this one, tenofovir and AZT and 3TC and dolutegravir. But because of, as I said, the fact that PIs don't require 2 active NRTIs with them, we can just give them tenofovir, 3TC, lopinavir, ritonavir. So that is what our experts have decided, just to decrease the pill burden. We don't have to add that AZT. Okay, so is everyone clear that for lopinavir, ritonavir, you don't have to, if they've got hepatitis B and you want to continue the tenofovir, you don't have to add the AZT. But for dolutegravir, if they're hepatitis B positive and you need that tenofovir, you have to add that in addition to the AZT. Okay, that's the important thing to note here. Okay, then second line regimens, if they were on a PI-based regimen for more than 2 years and had 3 high viral loads at least, So that would usually be our AZT, 3TC, lopinavir, or atazanavir. As per our old guidelines, we will do a resistance test for these patients. And then we'll see if there's no PI resistance, we will continue them on their PI. And we will expect them to suppress their viral load. If there is PI resistance, as per normal, we will then refer to the third line committee. Is that clear with everyone? And once we do the children's, the pediatric one, it'll also maybe solidify things a little bit. So in children, our second line regimens, if the patient was on an NNRTI-based regimen and they fail, if they are over 20 kgs, they can go on to dolutegravir. But if they are under 20 kgs, they will have to go onto a PI-based regimen. Then when they become 20 kgs, they could switch. And if they fail these ones, you could switch, but there's a big but here. Resistance test is required because we must ensure that at least one NRTI is active. Okay, so this is what we were talking about earlier. So you can't just easily switch from lopinavir, ritonavir to dolutegravir without knowing if your NRTIs are active or not. Then if your patient is still under 20 kgs and they are failing this, we do a resistance test. And that's as we used to already. If someone fails a PI, 3 high viral loads over a 2-year period, they get a resistance test. So that hasn't changed. It's just that, if you are considering changing to dolutegravir, you'd need a resistance test. So in children, the columns are the same, but it's a little bit more complicated. So our children who are on an NNRTI-based regimen, say abacavir or AZT or tenofovir, 3TC or FTC, and efavirenz or nevirapine, again, no resistance test is required. If they're under 20 kgs, they need to change to lopinavir, ritonavir. And then we're not too stressed about the NRTIs, whether they're active or not, so we can give abacavir or AZT. If they're over 20 kgs, we can change them to dolutegravir and 2 NRTIs, but in consultation with an expert, because we need to ensure that at least one NRTI is active. If NRTI activity cannot be confirmed, the expert will recommend 2 NRTIs and a PI, because that's the safer option, because we don't want to give dolutegravir and 2 inactive NRTIs. Okay, so does that kind of solidifies where you were thinking for the adults? It's just that we've put it into words for the children, because we care about them more. Then if the child is on a PI-based regimen for more than 2 years and is failing, we will do a resistance test as per the old guidelines. If there's no PI resistance, continue the regimen if they're under 20. If they're over 20 kgs, then you'll only, again, you've got a resistance test, so now we can, with an expert, decide whether this person could go on to dolutegravir, because we can use this resistance test to look at our NRTI resistance mutations and get 2 active NRTIs. But again, if we cannot confirm the NRTI activity, the expert will recommend 2 NRTIs and a PI. If there is PI resistance, then refer to third line committee, same as what we've been doing before. Then, if they're on an INSTI-based regimen, so say dolutegravir, in children we are doing resistance tests. So in adults we said only by expert consult can we do a resistance test, otherwise we'll just follow the algorithm. In children we are doing resistance tests, purely because there are a smaller number of people and we can fit that into our budget. If there's no INSTI resistance, we can give 2 NRTIs and dolutegravir in consultation with the expert, who will find an active NRTI. If there is INSTI resistance, refer to third line committee. from a kind of programmatic aspect is that we don't want to create extra burden on our healthcare system. So we aren't doing, as I said before, any additional viral load testing. We are continuing on our routine viral load testing as we were, and then we will change the people who qualify to change. So if a client has not had a viral load test in the last 6 months, additional viral load testing should not be done. And the number of months for which a client receives ART and the timing of the routine viral load testing should be aligned so as not to provide a client with a surplus of their original regimen when they are soon to be switching. So that's if you're seeing a patient today, you're thinking about switching them, so you take a viral load today, but then you give 3 months supply of ARVs, and then you tell them to come and get their viral load result next week, and then you change them to TLD. Don't give them 3 months supply of ARVs. I think it's common sense. And other program considerations for this introduction of TLD is to revise the HIV treatment guidelines. We have to train all healthcare workers, that's why you're all here. The pharmacy side is doing the planning and procuring of TLD. We will be updating registers and forms. We will be updating tier.net and the way things are captured to align with these guidelines. And we're going to have to assess the impact on other program changes. So our role as healthcare workers, we have the most important role, I think, to make it a success. We need to prescribe TLD to the right patients. We need to help prevent stockouts and wastage of ARVs by following the guidelines correctly. We need to counsel the patients correctly on why they're changing, do they want to, their contraception needs, etc., and keep the national program informed so challenges can be addressed quickly. We know that this is a big deal. Rolling out a new drug, there are going to be challenges that come up. Please just let us know. As soon as anything happens, let the team know, and then they can do something to help. So in summary, dolutegravir is a game changer in South Africa's ART arsenal. It's got a high genetic barrier to resistance. It's generally very well tolerated. But there are significant drug interactions, including rifampicin, metformin, anticonvulsants, the polyvalent cations. There are possible risks of NTDs, neural tube defects, so we do need to counsel those patients correctly and integrate our ART and our family planning services and record in our clinical stationery correctly. Viral load suppression is now defined as less than 50, viral load less than 50 copies per mil. Any viral load above 50 copies means viral replication with the risk of resistance, so action is required. Medical emergency, A, B, C, D, E. Do your intervention, repeat the viral load. Never switch only one drug in a failing regimen. If there is a viral load in the last 6 months and it is suppressed, they may switch to dolutegravir after appropriate counseling, etc. If the viral load is between 50 and 1,000, do not switch immediately. Progression to outright failure must be excluded by ensuring that the repeat viral load is now below 1,000. Remember that extra step that we put in for caution. And virological failure requires a complete regimen switch, including the NRTI backbone. So a change in PI or dolutegravir or efavirenz, and a change in at least one NRTI, one active NRTI. And resistance testing is indicated if a patient is failing a PI for 2 years with 3 high viral loads. That's in adults, and in children if they're failing either dolutegravir or a PI for 2 years with 3 high viral loads. Any final questions?